হুম, ঠিক আছে। Hello.
Hello.
Hello, technical team. Yeah, yeah, yeah. Am I audible and
Yeah,
visible
yeah,
properly,
clearly.
ma'am?
Yeah, yeah, clearly audible and visible, sir.
Ma'am, I want a favor from you people. Will this webinar be recorded and a copy given to me?
Yes, sir.
Okay, I want a recorded version of this webinar, and
Okay,
a copy
sir.
to be given to me.
Yeah, so Doctor, we are live now. We can start with the session.
Yeah. Hello, technical team.
Hello, yes, sir.
Yeah. Would you start with an introduction?
Sir, you can start with your self-introduction.
Should I start with my slides?
Yes, sir.
Yeah, I'm starting. Okay. Hello. Good evening, viewers. Good evening, everybody. Everybody. Good evening to the medical fraternity, the doctors, and the staff of Dr. Reddy's pharmaceutical industry who have taken the pain to arrange this beautiful webinar in this evening. Our today's topic will be glycemic happiness, the evolving concept in type 2 diabetes mellitus. The never-ending demands of diabetes care, such as eating carefully, exercising, monitoring blood glucose, then symptoms of low or very high blood glucose, then fears about or the reality of complications. So, diabetes distress defined as persistent emotional burden or worries that form a part of the spectrum of patients' feelings and experiences during the management of diabetes mellitus over time. A satisfactory blood glucose level increases happiness experience of the patients. So this is a beautiful diagram depicting positive psychological constructs, optimism, resilience, well-being, happiness, self-esteem, healthy behaviors, physical activity, diet, medication, adherence. So higher levels of positive effect, optimism, and well-being can lead to improved health behavior, adherence, and outcomes in patients with type 2 diabetes mellitus. Let's go over to the next slide. It is a case-based study. A 54-year-old Indian female with a past medical history significant for type 2 diabetes mellitus. She was first diagnosed with type 2 diabetes mellitus 6 years ago. Her most current physical and lab parameters revealed BMI of 31, waist hip ratio of 1.2, A1C of 8%. Renal and hepatic functions are within normal limits. Patient has been on metformin regimen for the past 5 years in combination with thiazolidinediones. Patient also complained of weight gain since the administration of combination therapy. There was no history of smoking and alcohol consumption. Vitals at the time of visit was blood pressure 120 over 76 and pulse 72 bpm. So what are the patient concerns? Patient concerns are weight, cost, glucose control, doctor strategies, minimal cost, minimal weight at gain, minimal efforts, minimal pills, hypoglycemia prevention, and organ protection, consider existing comorbidities. Decision after discussing merits of sulfonylurea addition. No other single MAD could match better the efficacy of pioglitazone. Economy to be considered. Safety wise, more economical. DPP4 inhibitors don't have cardiovascular outcome trials. Neither DPP4 nor SGLT2 inhibitors in isolation could control sugars, and patients resisted more pills. So decision was patient was put on glimepiride 2 milligram and metformin 1 gram twice a day. Diet and exercise were re-emphasized. Counseling was done for hypoglycemia prevention. What is the outcome of this case study? Patient was doing better after 3 months with A1C levels of 7.1%. Glycemic control. Different agents as add-on to metformin are there. The class of drug sulfonylurea with a mode of action of insulin secretagogue. A1C reduction in terms of percentage was found to be 0.8 to 2%, whereas in other groups it was lesser compared to the sulfonylureas, namely maglitinides, GLP-1, mimetics, biguanides, etc., etc. So sulfonylureas are potent glucose lowering agents with about 1 to 2% of A1C reduction. Changes in A1C and FPG from baseline to end of the study. This is a randomized open label parallel group multi-center study where 209 Korean type 2 diabetic patients received glimepiride and metformin fixed dose combination or metformin up titration treatment, as revealed by the two bar diagrams depicted on the left and on the right. So it is seen that glimepiride metformin fixed dose combination therapy was more effective in glycemic control than only metformin up titration. Changes in fasting plasma glucose and postprandial plasma glucose from baseline to end of the study. Start study. Open label randomized comparative multicenter study 305 type 2 diabetes mellitus patients who were either drug naive or uncontrolled on metformin were randomized to glimepiride plus metformin 1000 milligram once daily or sitagliptin 50 milligram and metformin 500 milligram twice daily for 12 weeks. Changes are observed in the glycosylated hemoglobin from baseline to end of the study as depicted by the two line diagrams on the right side. So it is seen that glimepiride metformin combination exhibited significant reduction in glycemic parameters as compared to sitagliptin metformin combinations. A second case-based study where a 62-year-old male patient with type 2 diabetes mellitus and hypertension having a history of since last 8 years. He was on metformin 2 gram a day, empagliflozin 25 milligram and linagliptin 5 milligram a day with no history of CKD or ischemic heart disease. Was regular with diet and exercise. Fasting blood sugar was found to be 160 and post lunch blood sugar was found to be 250 with A1C value of 8.6%. So what the patient wanted? Patient wanted a good glucose control and he was not keen on insulin. The doctor's dilemma was I have already used 3 oral anti-diabetic drugs. Will fourth one work? And finally decided to add glimepiride to metformin. Patient started on 1 milligram glimepiride plus 1000 milligram metformin as add-on to EMPA and LINA. So let's see what happens. After 3 months, there was significant reduction in FBG to 110 milligram per deciliter, whereas PPBG was 160, with a good reduction of A1C to 7%. So what is the lesson learned? We can't label patient as oral hypoglycemic agents failure currently with more number of available OADs. The conventional definition of 3 OADs may not imply that beta cell function is fully utilized. Hence, OAD failure can't be concluded till sulfonylurea have been used. There is a 5-year durability study with metformin. The original article states that important differences in the durability of glycemic response among second line treatment options when added to metformin in type 2 diabetes, a retrospective cohort study, where 20,070 patients were newly treated with a sulfonylurea DPP-4 inhibitor or thiazolidinediones following metformin therapy failure. In routine clinical practice, adding a DPP-4 inhibitor to metformin is associated with an increased earlier requirement for treatment intensification as compared to adding an sulfonylurea. Which one is more durable, sulfonylurea or gliptin? The left-hand side bar diagram represents adding sulfonylurea to metformin had a lower risk of treatment failure compared to adding DPP-4 inhibitors to metformin. Glycemic responses, glycated hemoglobin over time. Sulfonylurea added to metformin maintained a zero point 0.3 to zero point 0.5 greater reduction in A1C compared to metformin plus DPP-4 inhibitor. So sulfonylurea have got these benefits. Then one more case-based study with moderate CVD risk. A 55-year-old male with a history of diabetes diagnosed 10 years ago and had a moderate cardiovascular disease risk. BP was found to be 140 over 92 millimeter of mercury. There was smoking history from past 12 years. FVG ranged from 140 to 160 milligram per deciliter. A1C was found to be 8%. BMI was 29. He was on metformin 1 gram twice a day and empagliflozin plus linagliptin combination. So what the patient wanted in this case, he wanted cardiosafe medications at reasonable price. Doctor started glimepiride zero point 0.5 milligram plus metformin 1 gram in addition to empaglina combination. After 3 months, A1C was found to be 7.2%. Lessons from the CVOTs. Results can be postulated or extrapolated. Cardiovascular safety of one molecule can't imply for other molecules of same groups. In patients with high cardiovascular risk, medication use has to be judicious and rational. Only glimepiride has cardiovascular outcome trial amongst sulfonylureas. Most patients who have ischemic heart disease or complications of diabetes invariably need multiple medications, and sulfonylureas, notably glimepiride, retain respectable place over here. So glimepiride's cardiosafety parameters are it preserves myocardial preconditioning. There is no effect on reducing coronary artery blood flow. There is no effect on adenosine triphosphate sensitive potassium channels, and there is little or no effect on blood pressure. There is a population based study among 66,032 new sulfonylurea users. 6,438 initiated glimepiride and were matched to up to 20,582 initiators of other second generation sulfonylureas. All cause mortality and other adverse events were assessed between the two groups. So this is a chart indicating incidence rate of cardiovascular factors for glimepiride and other second generation sulfonylureas. Regarding myocardial infarction, glimepiride has got a score of 8.3, whereas for other just second generation sulfonylureas it is 8.7, far more than glimepiride. Regarding the ischemic stroke prenatal, glimepiride has got a score of 7.8, and for other second generation sulfonylureas it is 8.1. And also regarding cardiovascular death, it is 10.7 for glimepiride, whereas for other second generation sulfonylureas it is 12.9. So, use of glimepiride was associated with non-significant but lower incidence of myocardial infarction, ischemic stroke, and cardiovascular death. Let's talk something about the Carolina trial. Linagliptin versus glimepiride on major adverse cardiovascular outcomes in patients with type 2 diabetes mellitus. It is a randomized, double-blind, active-controlled, non-inferiority trial comparing linagliptin versus glimepiride in 6,033 patients. We find that glimepiride is non-inferior to linagliptin in terms of composite cardiovascular outcomes. So there is one more case-based study. A 75-year-old male with a history of type 2 diabetes mellitus since last 25 years, diagnosed in health checkup, started on glimepiride 1 milligram and metformin 1 gram a day. There is no end organ damage. Till now, A1C was found to be 7.1%. Patient was happy or is happy with existing regimen. A good number of patients who were picked up early and given rational combination therapy of glimepiride and metformin have maintained beta cell function and organ preservation, and this combination remains one of those which has evidence for longest duration. Glimepiride, its pleiotropic effects. What are the extra pancreatic effects? It improves insulin sensitivity, it increases adiponectin levels, and promotes glycogen synthesis. Regarding the anti-inflammatory effects, it reduces levels of interleukin 6, tumor necrosis factor, high sensitivity C-reactive protein. What about the cardiovascular effects? Less inhibition of KATP channels, cardio-safe profile, and other pleiotropic effects are angiogenic property, antioxidative effects, positive endocrine effect by increasing testosterone level in male patients. So these are the pleiotropic benefits of glimepiride. The effect of glargine versus glimepiride on pancreatic beta cell function in patients with type 2 diabetes uncontrolled on metformin monotherapy, an open-labeled randomized controlled study. So glimepiride is found to be as effective as insulin glargine in controlling hyperglycemia and maintaining beta cell function. Effects of long-term monotherapy with glimepiride versus glibenclamide on glycemic control and macrovascular events in Japanese type 2 diabetes mellitus patients. It is a long-term 5-year glimepiride therapy sustains beta cell function and enhances insulin sensitivity. Glimepiride, its safety profile. Here is a prospective population-based 4-year study to compare frequency of severe hypoglycemia in patients with type 2 diabetes mellitus treated with glimepiride with an N number of patients of 1768 versus glibenclamide with an N number of patients of 1721, almost same. So it is found that incidence of severe hyperglycemic events is much lower in glimepiride as compared to glibenclamide, as represented by the bar diagrams. So significantly lower incidence of severe hypoglycemic events were observed with glimepiride versus glibenclamide, that is 0.86 versus 5.6 per 1000 person years. A randomized parallel group study conducted in the type 2 diabetes mellitus patients comparing safety of glibenclamide and glimepiride. A total of 50 patients are included, 25 in each group. So in the glibenclamide group, we find that nausea, vomiting is more as compared to the glimepiride. Constipation is more in the glibenclamide group. Hypoglycemia is much more in the glibenclamide group as compared to the glimepiride group, as represented by the difference in the height of the bars. Weight gain is more in glibenclamide. Headache is almost equal in both glibenclamide and glimepiride. So in type 2 diabetes mellitus, glimepiride was associated with fewer episodes of hypoglycemia than glibenclamide. Effect of 12 months of treatment with glimepiride or glibenclamide on body weight. It is a multicenter observational study in newly diagnosed type 2 diabetes mellitus patients comparing the effects of glimepiride or glibenclamide treatment on body weight over 12 months of treatment. So results was found as follows. Treatment with glimepiride was associated with a significantly greater decrease in body weight than with glibenclamide while providing equivalent glycemic control. Regarding incidence of all-cause mortality, there is a population-based study among 66,032 new sulfonylurea users. 6,438 initiated glimepiride and were matched to up to 20,582 initiators of other second-generation sulfonylureas. All-cause mortality and other adverse events were assessed between the two groups. What is the result of this study? It shows that glimepiride was associated with a lower incidence of all-cause mortality compared with other second-generation sulfonylureas. So what are the trust factors for glimepiride? It is a 25-year-old molecule. It has specific site binding. It has action on both insulin phases. It has dosage convenience. It reduces insulin resistance. It has clinically proven safety profile, and its benefits are beyond glucose lowering. So glimepiride is a modern sulfonylurea. It is associated with lower risk of hypoglycemia and less weight gain compared to conventional sulfonylureas. Cardiovascular safety profile is similar to DPP-4 inhibitor, that is linagliptin. It is effective in reducing fasting plasma glucose, postprandial glucose, as well as A1C. Its once daily dosing may enhance compliance for diabetic patients with comorbidities such as hypertension. It is a cost effective treatment option for managing type 2 diabetes mellitus. Thank you for the patient hearing. Thank you, technical team. Thank you, Dr. Reddy's.
Yeah, so doctor, are we done with the webinar, right? So doctor, I see there's no question in the chat box. We'll wait for 10 to 20 seconds. If any questions, attendees will post in the chat box. Yes, so doctor, I see there's no question in the chat box. So with the permission, we'll conclude the session.
Yeah, sure.
Yeah, I would like to
Thank you.
thank you for presenting the session and sharing your knowledge with all the attendees. Thank you, sir.
Thank you. Thank you so much.